Yeah, we were very well
Here we
prepared.
are.
Better. Okay. Hello. All right. Welcome, welcome, welcome. Sorry we're 4 minutes late starting, but we will just dive right in. My name is Jane Wallen. Welcome. I work for Clyvera with Dr. Sud, and I lead the marketing communications for the company. We are developing an app that we have not launched yet, so we're going to encourage you to sign up so you can help us beta test. But we would love to start doing webinars with one of our co-founders, Dr. Rohit Sud. He is an oncologist and he has a wealth of knowledge to share with us. So today, for our first webinar, we are going to discuss breast cancer. Please note, this conversation is educational, not a substitute for personal medical advice. So please talk to your healthcare provider about your individual situation. All right, to start us off, Rohit, can you share your background as an oncologist, but also your connection to Clyvera?
Hello, everyone, and welcome to our first of many webinars. I am a board certified and practicing medical oncologist with experience of over 20 years. I've had clinical experience and research experience in various forms of cancers over the past several years. I trained at the University of Rochester in New York in oncology, and it was about 5 years back, 4 or 5 years back, we started thinking about artificial intelligence and leveraging AI to help our patients. And then with the help of some very smart and technologically savvy colleagues and friends of mine, we had a desire to create an AI health assistant, which could help users get faster, smarter, more curated information and insights about their health, including symptom analysis and tracking, storing and organizing medical histories and records. They could be better informed and have better discussions with the healthcare providers. So that was all. That was all the impetus that we needed, and my experience in actually seeing patients struggle through in discussing things with patients. We this seemed like a perfect segue to get into something that could help my patients beyond just being in the clinic, a 15 to 30-minute clinic visit.
Right. All right. So you and I worked on talking about what topic we wanted to start with, and we picked breast cancer because it touches so many lives. So it felt like a good place to start. Before we jump into more granular questions, Rohit, I wanted to ask you why you think breast cancer awareness is such a critical topic, even with all the medical advances that we've made.
Yeah. Thank you, Jane. It's a wonderful and a very pertinent question. Breast cancer is the most common cancer diagnosed worldwide. For example, in the United States, we'll have about 300,000 cases of breast cancer diagnosed each year. Wow. With a mortality of about 40,000 patients. So it's still a very real disease that can afflict many people around us. So breast cancer mortality rate, however, has been decreasing since early 70s due to breast cancer screening and advancement in treatments. So in this era of social media and information being readily available, manipulated, what have you, we do see patients having multiple questions and misconceptions about breast cancer. So any place that we can actually have more awareness, more educated awareness on several topics like breast cancer, which does impact so many people, it is great. The range of understanding from breast cancer to the myths surrounding it, and being aware of the risk factors and medications that we use to treat breast cancer is always helpful to actually have patients have a better discussion or understanding of their own health. So because it touches so many lives, we decided breast
talk about it.
Was
a
perfect topic to get into.
Yeah. Okay, so what is one thing that you wish every person understood about breast cancer from the start?
So here's a statistic which may be glaring. 1 in 8 women in the United States will be diagnosed with breast cancer.
Wow.
I don't want to shock anyone, but that is true. The chances are that we know someone who has been physically affected by breast cancer. Early cancer detection is the key, and screening tests like mammograms and ultrasounds are very effective in early diagnosis, which with current treatment protocols has improved lives. We are seeing that 99% of patients with early stage breast cancer have no issues. The survival rate has reached 99%. The 5-year survival rate has reached 99%.
Wow.
And so it is an attribute to good awareness and early detection and treatment methods. And kudos to Susan G. Komen Foundation and others like it who have actually done an amazing job in increasing that awareness. We do see even NFL getting into it with their pink laces and stuff like that.
Yeah, yeah.
So awareness of these statistics is the key in empowering, I think, individuals to make informed decisions about their health. So that is one thing that I wish people understood, that when your doctors tell you to go and have a mammogram, it's important to adhere to those recommendations, because they do help save lives.
Well, and as a woman who delayed her mammogram once, it's really easy to get the letter from your doctor and go, yeah, I'll schedule that. And then 6 months go by, and it's really early. Like you said, catching it early is so key. So key.
Absolutely. Taking our own health in our own hands and being proactive about it is the key in this and many other cancers.
Yeah. Yes, absolutely. So I would love it if you could just tell us, we're going to go super basic. What exactly is breast cancer and how does it typically develop?
Okay. So cancer is a term that we use. It's a class of disease that is characterized by like an abnormal cell growth that invade healthy tissues and healthy cells of the body. Now, cancer usually begins as normal cell growth that undergoes some abnormal physiological pattern of growth, develops certain mutations, and the cell growth process goes awry and wrong, and new cells are formed which harbor these mutations, which make them resistant to their own cell death, the programmed cell death that we tend. So they don't die as they normally should and recycle in the body. And when this occurs, these mutated cells, they may continue to grow at a much more rapid pace than the normal cells. So they have a growth advantage as compared to the normal cells because of these mutations. That can lead to a buildup of cells, which can often be seen as a lump or a growth in the body. And eventually, additional mutations can take place because these are unstable genetically, and that can lead to cancer spreading. So that's how cancer in general forms, and that's how breast cancer forms. That's how other kinds of cancers also form in the body.
Okay.
Many times these are driven by certain factors that are exogenous. Sometimes they are not. But that's the basic crux of how cancer forms in the body.
Okay. Are there different types of breast cancer? And if yes, how does that impact treatment?
Oh, well, that's a webinar in and of itself.
Yeah, I know. I think each question is a webinar here.
So there are multiple different kinds of breast cancers, ranging from non-invasive stage 0 breast cancer, which we call ductal carcinoma in situ, which has not spread through the tissue of the breast, involving any local lymph nodes, or has the potential of even spreading to the rest of the body. These are called stage 0 for a reason, because they are still within that cell when we actually are able to identify a cluster of cells, I should say, when we're able to identify. And that is why mammograms are of utmost importance, to actually try to identify it when they are still in that cluster of small cells. And they are highly treatable and curable. So these are called ductal carcinoma in situs. The next phase is the invasive ductal carcinoma, which begins in the milk ducts and spreads through the surrounding tissue to the other areas of the body that might lead to an invasion. So these invasive ductal carcinoma start from the ductal carcinoma in situ, but then they invade through the wall of the breast into wall of the ducts, I should say, into surrounding breast tissue and eventually involving lymph nodes.
Okay.
Now, there are other breast cancers, such as invasive lobular cancers, which begins in the milk glands, not in the ducts. And these behave slightly differently than invasive ductal carcinoma. Tend to occur in both breasts and in many patients, but also has a propensity to actually spread to surrounding tissue and to other parts of the body.
Okay.
And then there are various other kinds of breast cancer, some of which tend to have hormone receptors on them, which impact what kind of treatments we offer them. Some have certain receptors. You must have heard HER2, where these are targeted treatments that can these are targeted I should say subtypes on the cell types, antigens that can actually be used to create antibodies that we use to attack these cancers. In addition, there are various other rare variants, such as inflammatory breast cancer, which is more aggressive and a fast-growing cancer, and tends to actually present like an inflammation in the breast, like redness, a painful rash. So there are many different kinds of breast cancers, but the best way to figure out what it is effectuated by a biopsy to further then study the molecular patterns and defining whether they have hormone receptors or whether they have HER2 receptors to actually define treatments better for patients. So it all starts with initial imaging to get a mammogram, ultrasounds, biopsy, and then leading on to further molecular studies on the specimen that's taken out.
Okay. That's a lot of different types of breast cancer.
That's what I said. It's a webinar in and of itself.
Yes, it is. How common? We talked about how common breast cancer is, but who is most at risk?
So breast cancer, as I said, 1 in 8 women in their lifetime will be diagnosed with breast cancer. So, for example, in 2025, over 300,000 women and 3,000 men were diagnosed with breast cancer, with invasive breast cancers.
Wow.
Additionally, 60,000 had non-invasive breast cancer. So the stage 0, as we talked about. So it is fairly common. There are multiple known risk factors, and for example, it's 100 times more likely that women will have breast cancer than men. For multiple reasons, including their hormonal makeup and stuff like that. But it is definitely more common in women, and that's why we hear more about breast cancer in women. But it does also occur in men.
So with men, given that they're not starting regular mammograms at a certain age, what do they generally find their cancer later stage?
Very good question. So most men do, unfortunately, detect their cancer much later, unless the man itself, with some heightened degree of suspicion because of family history, tends to, feel a lump or a growth around the nipple area and brings it to the attention of their physician. These can go unnoticed and ignored for a much longer period of time. Yeah, so it is definitely, you're right. As the folklore goes, that it only affects women. No, it does not. It is something that's common in men as well. Not as common, but it cannot be ignored, especially in high school. And we talk about the risk factors, I'm sure, further in the podcast. But
it's actually, that's our next question. So I think this is a good segue.
Yeah.
What are the biggest risk factors, both genetic and lifestyle related? And then, I think, let's just talk about that. Let's talk about that.
Okay. So there are multiple risk factors. So, so about 60 to 70% of the breast cancer, I must say that they have no association with any risk factors at all.
Oh, 60 to 70%?
Yeah.
Wow.
So 30 to 40% patients will have certain risk factors that, so 60 to 70% of cancers that we see are essentially random. And people with risk factors, some people who have multiple risk factors will never develop cancer. Just like, you hear that, My uncle was a smoker and he never got
Mm-hmm.
lung cancer,
Yeah.
but lung cancer is associated with smoking. So,
Yeah.
those kind of stories you hear in breast cancer as well.
Okay.
So many people who have risk factors will never develop cancer. So, age is a big risk factor. So people who
Mm.
are older, we do see more commonly get cancer as over 55 years of age, as we say. In addition, early menstruation, if your menstrual cycles, the women start at around age 12 or before, and
Mm-hmm.
they enter into menopause much later after 55, their risk of having breast cancer is higher.
Hmm.
And in people who
So
have
that's having a longer
a longer period
overall
of
period of.
overall exposure to the hormonal,
Okay.
I would say the hormonal cycles, essentially.
Interesting. Yeah.
um, uh, you know, Essentially unopposed estrogen
Hmm.
exposure.
Okay.
For example, even women who have their first child at a much older age or have never given birth, they have an increased risk of breast cancer.
Mm.
So there are these factors that definitely do tend to be. There are, family history, of course, is a big
Mm-hmm.
factor. There are certain genetic mutations, for example, most commonly BRCA1 and BRCA2 mutation that
Mm-hmm.
increase risk of breast cancer and other cancers as well. And there are multiple other identified genes that actually put patients at risk of breast cancer. In addition, there are environmental and social factors. Patients with a high BMI are at an increased risk of breast cancer.
Mm-hmm.
A sedentary lifestyle, there is some association about an increased risk for breast cancer. A poor diet, which is high in saturated fat
Mm-hmm.
and lacking fruits and vegetable, has been variably associated with both being overweight and increasing the risk of breast cancer.
Okay.
Alcohol consumption, more than two alcoholic beverages a day, can increase your risk of multiple cancers, including breast
Mm-hmm.
cancer.
Interesting.
So, there is additionally, hormone replacement therapy was much in the news for the past several decades about
Mm-hmm.
increasing the risk of breast cancer, especially in postmenopausal women. The jury has been out lately, but I
Yeah.
think still the recommendations and the common society guidelines do suggest that at this present time that it is still something that is a risk factor.
Interesting. So genetically, you mentioned BRCA1 and 2. Who should get genetic testing? And if you discover you have the gene, what does that mean? What do you do next?
Okay, let's talk about. So there are multiple genetic mutations that
Mm-hmm.
cause breast cancer. BRCA1 and 2 are one of the more common ones, but patients with an extensive family history, especially if the mother, sister, father, or child has been
Mm-hmm.
diagnosed with breast cancer or ovarian cancer, they have a high risk of being diagnosed with breast cancer in the future.
Mm-hmm.
So that is in and of itself, aside from actually having a BRCA a mutation, these patients may benefit from such hereditary testing.
Mm-hmm.
So that risk is higher if your
Mm-hmm.
relative was diagnosed before age 50,
Mm-hmm.
and such patients should be offered early screening and possibly also genetic testing.
Mm-hmm.
So, the specific genetic mutations that we have that predispose to breast cancer are rare, however. So not all patients who tend to have a family history will have these genetic mutations. Only
Yeah.
6% of all breast cancers are directly linked to BRCA1 or 2 pathologic
Oh,
variants.
wow. Okay.
94% of our breast cancers that we see, even if they have a family history or they are earlier age of onset,
Mm-hmm.
tend not to have the BRCA1 or 2 mutation. And as we said, that 60 to 70% of breast cancers do not even have any risk factors.
Yeah.
So patients who have these mutations, they are definitely at high risk of breast cancer, ovarian cancer, endometrial cancers.
Mm-hmm.
Males with these mutations tend to have an increased risk of male breast cancer and prostate cancer. So those are risk factors that need to be investigated and should be looked at. There are other rare form of genetic mutation. There is Li-Foraminee syndrome, which is associated with multiple cancers, including sarcomas, certain leukemias, and inappropriate patients and family histories. These are genetic variants that we do look for. The good news is that we do have certain genetic tests that are available to your doctor, called Invitae and Myriad Genetics, both run out of California. And these companies run a gamut of tests on the genes and are able to identify pathogenic variants of BRCA1 and 2 mutations. They're able to find the Li-Foraminee and other mutations that might actually cause such things. And our case was much brought to public attention by Angelina Jolie, who had tested for this and had a BRCA mutation, and that led to her making some drastic changes and decisions. And why I bring that up is because she did talk openly about her struggle with making decisions. And we do see this in our clinical practice, how patients struggle about it. Like patients without a history of cancer, and who are diagnosed by such testing with these mutations, we are obligated to discuss factors that they can do to reduce their risk of having cancer. So like bilateral ovarian removal and fallopian tube removals, and removal of both breasts. They are best done between age 35 to 40. And that's a pretty young age for someone to actually
make that decision.
That's big. People are delaying childbearing at this time, and family planning, and that is prime time when women are getting pregnant. So talking to them about removing their ovaries and not having children, and removing their breast, which is an important it's a body image issue. It's a sexual function issue. So it's not something that is easy to discuss, with women at that age. But that's something that we do for risk reduction. We do talk about this, and it's a very difficult discussion. I've been with women agonizing over these decisions, and families, torn apart. We do have other, thank goodness we have screening tests, which are good. We do tend to do, frequent surveillance if they choose not to do anything like this, like mammograms frequently, or MRI of the breast, which insurances do tend to approve once they do see that these patients are not having their mastectomies or oophorectomies, and they are at high risk because of these mutations. They do approve mammograms and MRIs much more frequently, and beginning at age 25 in those patients.
Oh, wow. Oh, that's good. So that's really good.
Much earlier. And patients who elect not to have these risk-reducing surgeries despite having high risk, there are certain medications like tamoxifen that we can give, of course, after appropriate discussion of the risks and benefits that such an intervention may pose on an individual basis. We talk to them, and that can decrease the risk of breast cancer.
So which leads me to my next question, and that was more on the genetic front. But what are there lifestyle changes that do have a meaningful impact on risk that it's worth doing?
So in addition to, of course, mastectomy and ovarian resection and medications that we just talked about, which are not easy.
No.
But patients who are at high risk of breast cancer, there's additional data that breastfeeding. We get that the duration of breastfeeding when women are in the lactation phase may decrease the risk of breast cancer. So there's some solid data about that. There is data about weight loss,
Hmm.
and especially in postmenopausal women, that decreases the risk of breast cancer.
Wow.
Um, Increase in physical activity. The society does tend to recommend that's the American Cancer Society does tend to
Hmm.
recommend about 45 minutes of physical aerobic exercising, 4 to 5 times a week,
Mm.
because all these have been associated with a decrease in risk of breast cancer and also other cancers.
Hmm.
There's, of course, a low-fat dietary pattern, as we alluded to earlier, also decreases. There's inconclusive but data, but the diet rich in fruits and vegetables.
Hmm.
There is low evidence of data that suggests that can decrease the risk of breast cancer. A diet rich in calcium and vitamin D can also
Hmm.
positively impact, but the data there is not very robust, and it is
Okay.
um, really something that I wouldn't say that if you do that, I'll be free from breast cancer. That's never the
Yeah.
case. No.
Right. Right. What? So you've talked a little bit. What are the screening options, and who should be screened when? And I guess, yeah, we talked about, yeah, just tell us what the options are, and the whole
So
thing.
I would say there is no substitute to actually being aware of your body,
Mm-hmm.
and seeing a doctor if there
Mm-hmm.
is any concern. So breast self-examination has for a long time been advised to women,
Mm-hmm.
but but ignored by many of my patients.
Mm-hmm.
That breast self-examination on a monthly basis. For men, if you see a lump, you would be alarmed and you would probably go. But women, it might get missed unless there is a concerted
Yeah.
basis of actually of doing it.
Mm-hmm.
So,
I
so
like my primary care years ago, she gave a really great analogy. She said she walks the same path with her dog every day, right? And so she knows the path really well. And if it changes, she notices. And she said it's the same thing if you're doing a regular breast exam, because there are
Mhm.
natural lumps in those things.
Right.
The path, and then if the path changes, you can feel it, and that's why it's so important to do it so
Exactly. Exactly. So
consistently,
it's
right?
that self-examination is of utmost importance, and we'd suggest to do on a monthly basis.
Mm.
Bearing in mind that it's around your periods and whatever, because
Mm-hmm.
that can actually impact
That can
the
impact
the
things.
the shape and of the breast, and
Mm-hmm.
how firm it might be.
Mm-hmm.
Additionally, the clinical breast examination should be performed by every healthcare provider at the visit,
Mm-hmm.
which includes a visual and a physical examination of the breast. Mammograms are important, and they're gold standard, as we said, as a screening study
Mm-hmm.
for early detection, and is recommended for women 40 years and older to have a
Mm-hmm.
mammogram every year. And women at
Wow.
higher risk, uh, you know, especially with genetic mutations and family
Mm-hmm.
history,
Mm-hmm.
even as early as 25.
Wow.
So those annual mammograms are still the gold standard screening studies in addition to the breast examinations.
Okay. What are the most common early warning signs of breast cancer? And are there symptoms that people often ignore or don't realize could be serious?
Yes, there are symptoms that patients do ignore. Um, you know, a lump and thickness in the breast, under armpit, can actually be quite commonly recognized and brought to the patient's attention.
Mm-hmm.
Sometimes there are subtle things like tenderness around the nipple area, which may be just brushed aside many times, but that can be a sign of something bad happening. A
Mm-hmm.
change in the texture of the breast, the skin texture of the breast, particularly if there is unexplained changes in the size, shape, dimpling in the breast anywhere. These can actually try to identify a clinical concern for at least something that needs to be taken a look at. If it's not breast
Mm-hmm.
cancer, it could be something else. It could be
Great.
an
Right.
inflammatory disease in the breast. It could be Paget's disease, as we see. If there is dimpling of the breast, if there is shrinkage of the breast,
Mm.
that that also growth in size or shrinkage in the breast should actually be brought to the doctor's attention. If there is inversion of the nipple, it should be brought to those are things that I think a trained physician should
kind of
take a
like
look
your
at.
skin, right? If anything changes, talk to your doctor.
Yeah, absolutely.
Can you walk us through the main treatment options? I think we all kind of like, if you haven't had it yourself and dealt with it, you sort of know the words: surgery, radiation, biopsy, chemo, hormone. But can you kind of like high level, simple terms, treatment options?
So that's like explaining, I can give you a broad overview because, it
Well,
is,
and it has to become so personalized, right?
it
Too.
has to become
Yeah.
personalized eventually. And
Yeah.
that's why I said this is not a medical advice. This is more so just for common
Educational. Yep.
educational purpose. Just like when I'm sitting with my wife, who does not like football and is not into football, when I try to explain to her that there are four downs to a 10-yard game, she does not understand that. Why does this keep happening? But
Why did we reset?
exactly. So it varies greatly from patient to patient, and the type and stage of the cancer that we see. The molecular studies which we talked about, the hormone receptors, HER2 receptors being positive or not. So most local cancers are treated with surgery, in the form of either lumpectomy or mastectomy, which may or may not be followed by a post-operative radiation to that local area. Sometimes it could be followed by hormone therapy or occasionally chemotherapy, and we do extensive testing, including molecular tests now, to curate patients who would benefit from one or the other, so that the dictum of medical care is do no harm. So we try to actually and use all the technology that we have today in our midst to try to define what kind of patient will benefit from what kind of treatment. For more advanced cancers, of course, there's hormone therapies to actually mitigate to what we call as hormone ablation therapy, or basically, try to avoid the effect of the estrogen that actually drives these cancers, and also targeted therapies. There is immunotherapy that is up and coming in various cancers types of breast cancer that we can use, especially patients who do not have HER2 receptors or hormone receptors. These are used, and many of these treatments have actually had favorable side effects as compared to the blanket chemotherapy that we used to use.
What is an immunotherapy? What does that look like?
So immunotherapy is basically, our cancer, as we talked about, that has mutations, and so these mutations try to bring out certain antigens on the surface of the cancer cells that can be exploited by our immune system. But because these antigens are also present in other parts of the body, the immune system does not recognize it. Right. So we have drugs that we can use to prime the immune system to attack the cancer, and using those antigens. And of course, there are some collateral damage with toxicity that occurs at other parts of the body because of that. But that's what immune therapy does. It uses your own immune system, teaches it to attack the cancer.
I am just thinking, I have a good friend who's been dealing with breast cancer the last few years, and when it first came, and this was something that I learned that I think is really valuable, and maybe you can speak to it, but it was a double mastectomy and then radiation. And then 2 years later, she felt a lump in her armpit, and it was breast cancer. But when they did the testing on the cancer, it was different. And that cancer was responsive to chemo, whereas the first one wasn't. So her treatment the second time around was actually quite different than the first time around. She just was, really unlucky and and got that second different cancer. Anyway, that was something that was really, really interesting to me, that even within the same person, she ended up having different treatment needs.
Yeah. Now we're getting into the nitty-gritty of how cancer can morph.
Yeah.
These are genetically unstable disorders. And so, the first thing that we do whenever we see that the cancer come back is to rebiopsy it. Not all cancers, but certain cancers which are genetically inherently unstable,
Yeah.
and rebiopsying them to try and find out what kind of cancer had they become now,
Yeah.
or is it something different? And
So it could
so,
be the original cancer evolving into something new.
exactly. And that's how treatment protocols and treatment algorithms and our understanding of the cancer evolves.
Okay. What role does genetic testing play in treatment? Not prevention, but treatment. Does it play a role in treatment?
Yes. The genetic factor clearly determine what kind of surgery that you have. Like, so if a person comes in, a younger woman comes in with breast cancer, or a man comes in with breast cancer, um, uh, um, you know, and they have a BRCA1 or 2 mutation, we do offer bilateral mastectomy, and in women, ovarian removal in addition, because these are risks, because we know that, okay, they have had this. So
Yeah.
this is something that, so 85% of patients who have BRCA1 mutation will have breast cancer,
Wow.
and 65% will
Wow.
have ovarian cancer.
Wow.
So having known that you've had it, so you are at a high risk already. You will
Yeah.
have an ovarian cancer. So those discussions then tend to take a different urgency on. I've had patients who have been pregnant and diagnosed with BRCA1 mutation breast cancers, and it takes on different meaning altogether in those times.
Yeah.
But genetic factors do play a role in determining what chemotherapy or target treatments even we use. Certain of these genetic mutations, like BRCA1 mutation and 2 mutation, tend to have certain drugs that we now have approved, called PARP inhibitors, that can be used in appropriate situations, um, uh, even after local treatment for these breast cancer, to minimize the risk of their cancer coming back.
Okay.
And majority of that information, whether this would be applicable to that particular patient, is based on the molecular studies that we do from the breast specimen that's taken out.
Yeah.
To understand the inherited germline mutations, and see if the cancer itself has had new somatic mutations, as we call in the cancer itself, developing some mutations that are
Okay.
not inherited.
Thank goodness for you doctors, huh? Helping us out here. Okay. We're going to pull out of like treatment and the science. What are some common myths about breast cancer that you would like to clear up? Because there are so many things out there.
Yeah, there are many to get to, many of them. I get asked so many times. The doctor, I was in this car accident, and it hurt my chest. My airbag deployed. Do you think that my cancer is because of that? Or they have a hematoma that causes a buildup of this mass or muscle, and they're concerned. Their primary doctor refers the patient over to us, and it's just a hematoma, but they are concerned that, okay, my aunt or uncle had breast cancer, or someone had breast cancer in their friend circle, and that could this be breast cancer? And
Yeah.
um, I do lend a ear to them and go over the possibilities, imaging, and processes. But I have to say that injury does not cause breast cancer, although breast cancer can be diagnosed on imaging that is
From
done
an
as
injury, right?
part of the part of the injury, but it's not from the injury
It's
that you
not
had
related.
breast cancer.
Yeah. Yeah.
So, additional myths that actually we do get asked about is that, is it more common that women with bigger breasts tend to have breast cancer? And there is no connection between breast size and cancer. This is where size does not matter. It is an equal opportunity. It affects everyone. And the best of the most common of them all, and you heard it here: sugar does not cause breast cancer. Overconsumption can lead to obesity, and other health
Which
issues,
could increase risk factor. Yeah.
which can increase, but it does not cause breast cancer. So it's important to actually, people who have breast cancer say, should I just avoid sugar? There is no data, and you might be doing a disservice to yourself, because then if you are not having enough caloric intake, you don't have the strength to fight the cancer, because the cancer
Interesting.
is going to get its own nourishment from your body, leaving your body deficient. So I get this cancer a lot, this question a lot, that doc, does I put my cell phone in my bra, do you think it causes cancer? um, it might not be the most comfortable choice to put it in your bra, but sometimes it's convenient, I would think, to carry your cell phone there.
Yeah.
But yes, it does not cause breast cancer.
Okay.
So cell phone exposure directly into the breast tissue is not a reason that you would have breast cancer.
Okay.
The other question I get is about underwire bras.
Mm-hmm.
Do they increase risk of breast cancer? There is no data to support that, that any kind of bras increase breast cancer. And there's no evidence to support that going braless reduces your risk of breast cancer as well, because that's also
Okay.
another question you get.
Okay. Okay.
So, people many times even question, that, oh, radiation exposure gets cancer. So why should I get so many breast cancer mammograms, and why should I get that compression of the breast? This increases risk of breast cancer. It does not.
Okay. So getting a mammogram is not, it's not going to increase your,
not a risk factor, right?
Yeah.
And of course, the biggest is men cannot get breast cancer. Men also have breast tissue, and although rare, they can get breast cancer. So there is, we use of deodorants and antiperspirants do not increase your risk of breast cancer.
Okay.
And there are many, many, many more myths. I'm sure that we can talk more about it.
Yeah.
But yeah, these are the common
Those
ones.
are the most common. Yeah. That you hear. Yeah. Good. That's nice that basically all of them are myths. If it sounds like a myth, it's a myth.
Yeah.
Okay, before we finish up, let me get into our question window. Does anyone have any questions? Oh, we have a scientific kind of question here. Going back to when you're talking about the cancer cells, do these antigens only appear on cancer cells?
So some antigens are unique to certain cancer cells. And of course, every single cancer is different, but we are talking about breast cancer specifically. So certain antigens are unique to breast cancer cells, but they also tend to, but majority of the antigens that we target also are present to some various degrees on other body organs as well, and hence whatever treatment, even targeted, that we do give, and immunotherapy that we do use, can actually affect the other parts of the body, hence causing toxicity. So it's about how much the preponderance of these antigens is more on specific cancers. They're not unique to that cancer.
Okay. Are there any ethnicity factors with breast cancer?
So yes, so although breast cancer is more commonly diagnosed in Caucasian women, let's talk about only women. Of course, we talked about men and women both being at risk, but talking about women, Caucasians are more commonly diagnosed with breast cancer, but breast cancer tends to be more aggressive in African American women. It also tends to be diagnosed at a later stage in African American women. Much of that has also to do with access to care in certain populations, but African American women are at a higher risk of the same stage. To stage comparison of breast cancer.
Yeah, so diagnosed at the same stage, higher risk of it being aggressive.
high
Mm-hmm.
risk of being aggressive and high mortality rates.
Interesting. Ugh. Okay. Let me see. Do we have any other ones? Can treatment affect my fertility?
Yes. And that is a very nuanced discussion between the patient and the doctor.
Mm-hmm.
And the status of the patient's current. As I said, I have had patients who have been pregnant and have had certain various different kind of cancers that require us to navigate that path.
Mm-hmm.
I have had so patients who have got chemotherapy do tend not to be at a decreased fertility risk rate. They also, certain cancers, patients do get chemotherapy that can put them at risk of some mutagenicity, and these cancer, the eventual child may have some genetic mutation. So we have to discuss all of these.
Mm-hmm.
It's common practice amongst doctors to take women who are childbearing and do like cryopreservation of the ovum, or see and have them see a fertility doctor before we begin any treatment planning.
Okay. You mentioned sugar isn't fueling cancer. What about alcohol?
So alcohol consumption does increase risk of breast cancer and
Okay.
other cancers as well. Many societies are moving again, moving to actually decrease alcohol consumption. Recently, there was the Canadian equivalent of CDC said any amount of alcohol consumption is bad for your health,
Mm-hmm.
and so have many European organizations moved. It you know I It's a moving target for
Mm-hmm.
us here. CDC currently says alcohol in moderation. Last year CDC's recommendation was that more than two alcoholic beverages is bad. So I think those are all things to consider as
Mm-hmm.
we go.
Birth control. Does that
So
increase risk?
in high risk patients with BRCA mutations, we do talk about that as
Hmm.
increasing that risk.
Hmm.
But otherwise, birth control does not increase risk of breast cancer unless you have a strong family history and other risk factors.
Okay. Okay. Okay.
But
That's. Oh, go
hormone
ahead.
hormone replacement therapy, which is different, which
Mm-hmm.
is postmenopausal women, that tends to increase risk of breast cancer.
Interesting. Okay, but you said that's something that's sort of evolving, right? Like
That is
maybe.
also evolving.
Yeah.
The data for now still is that it is not something. It should be something that has a nuanced discussion with your doctor.
Yeah.
Uh,
Like risk versus benefit type
exactly,
thing, right?
case by
Yeah.
case basis.
Yeah.
Yeah.
Yeah. Okay. That's all of our questions that came in. Thank you, everyone. Where can before we go, where can viewers go for reliable, understandable information about breast cancer?
Well, so the internet is full of understandings, misunderstandings, conceptions, misconceptions, what have you, about various kinds of things, right?
Mm-hmm.
And you know, and my co-founders and I would like to think that having something which is more curated to a person would be useful. So I think that as an oncologist and as a physician, I feel it's helpful for patients to act and caregivers to have that element of support, to
Mm-hmm.
have vetted and curated data that is trustworthy for them to
Mm-hmm.
actually to work with. So
Mm-hmm.
patient living with cancer and caregivers supporting them, I feel that Clyvera itself can act as a trusted digital companion
Mm-hmm.
that can help reduce uncertainty, improve communication, and ease day-to-day anxiety and decision making. We talked about how we eventually see Clyvera as a portal where people can actually log their symptoms, side effects, medications, lab results, questions as they arise, and rather than trying to recall everything during a short medical appointment, this can be created as like a PDF format and shared with your doctor. The caregivers can also benefit by having this shared visibility into the patient's health data and updates. They can track changes. And many times we have uh, we have patients in our family members, including our parents who are getting older, and it's important to actually have they have less understanding of their own health and ability to actually process information. So I think having a digital format that can be transported in between the patient and their caregiver is good. And Clyvera aims to provide that safe, judgment-free space where sensitive, small questions can also be asked, which you may not want to ask your doctor at that moment, and you get vague answers from the internet. So those are all things that I think in a digital world today, and using AI to actually help us navigate that. It's only going to be helpful if we can curate that to create something
Right.
that.
Right. You want a smart AI that's getting to know you and also is pulling from reliable sources where you can trust it, right?
Yeah, so I think patients and caregiver can use Clyvera app to generate, all these, questions and share it with their medical team, and concise summaries with their medical teams, and basically take their own medical data in their own hand.
So since Clyvera, we're not out yet, where else can they go for some good information, for some support?
So I always
we all know Googling your symptoms is a bad idea. So how do you guide people?
For all my cancer patients, I always tell, for breast cancer, of course, you can go to breast cancer. The National Breast Cancer Society is a good one. Like we talk about the nationalbreastcancer.org, cancer.gov. These are, which is the National Cancer Institution supported website that has vetted information. These they tend to have also help regarding copay assistance and support systems that you may have. You can also go to Mayo Clinic information page for more accurate information about all of that.
Okay, those are great sources.
Yeah.
Thank you. Okay, last question. If viewers take away just one message today, what should it be?
Breast cancer is curable in early stages. So get tested. Remember that it is a very common cancer affecting 1 in 8. So surveillance is paramount. And we all eventually want to live in a world free of breast cancer. And today, how we can do that is by early detection.
Early detection.
Yes.
All right. Thank you so much. This was amazing. A lot of info. We got in under our hour, but I'm sure we could have gone longer.
Absolutely. Thank you, Jane. You are a delight to talk to.
Thank you. You too.
And I hope that you guys got something valuable out of this webinar, and we hope that you can join us for many more in the future.
Yes, there will be more. Thank you. Thank you, Rohit.
Absolutely.
Okay. Bye.